It's a great pleasure to be here, and as I say, to see so many guests in the audience, including my family, my friends, and also a number of colleagues from Glyndwr University and from wider afield as well, especially from Liverpool, so it's nice to see you here too. I hope you enjoy the lecture, and I appreciate your support. So obviously I've had a nice introduction already, and some of you know me, but for those of you who don't, I'm Fiona Irvine, Professor in Nursing, and since November also Dean of the Institute of Health, and in that role, Health, Medical Science and Society, I'm responsible for 5 departments, including Health Science, Applied Social Science, Early Childhood Studies, Education and Psychology, and it's nice to see some of you represented here tonight. Now, as you can see, it's a nervous thing delivering a professorial lecture, and it's a bit daunting, especially in front of a large audience like you. But the nice thing about it is it does give you a little bit of a chance to be a bit self-indulgent. Think about yourself for 5 minutes and reflect on your career. And so not wanting to miss that opportunity of my 15 minutes of fame, let me share some of the highlights of my career with you. And, you know, it's not just self-indulgence. There's a valid reason for doing this. Because the literature says, and my experience tells me also, that in research, and especially qualitative research, which is my bag really, the researcher really does have a significant effect on the research. And so it's really important that you have some sort of self-awareness, awareness of how you play your part in the research. And again, that gives you the opportunity to be critical and to be rigorous and to be a little self-indulgent. So authors such as Cutcliffe and Chalmers, whom many of you will know, contend that researchers should openly acknowledge these influences and make them known to the readers of their research and to you tonight, the audience of my research. So of course that gives me a great excuse to reminisce. When I was preparing this lecture, it allowed me to have a look at a few fun photographs and family photographs, and I'm going to share some of those with you tonight as well. So enjoy, I hope. So how does a lovely little girl like this end up working in specialist nursing and influencing specialist nursing? Well, dyma fi heno ar y traeth yng Nghennewydd on the beach in Newquay with my family, my sister and my mum, and there with my siblings, aged about 2, I think they're in the blue dress on the top left-hand side, looking pretty good, I think. Very shy child. And some pretty dubious haircuts, I think, there. And it's always, my hair is always worrying me since, so I think it's thanks to my mum. My girls say that about me now as well. Now then, research, and especially qualitative research, does ask you to reflect on your work and identify what's gone well and what's not gone so well. So, maybe photos like this are worth reminding you that sometimes, you know, if you feel a little grandiose about your position, you have to remember what actually didn't go quite so well. And clearly this photograph is the epitome of that. I think you could say that this early attempt at supermodelling didn't come out quite so well, but hey. The Glyndwr University mission is that this university strives to be a market-led, student-centred university of international significance and open to all. And in his welcome address, the Vice-Chancellor, Professor Mike Scott, says these words: "At Glyndwr University, we don't believe that there should be barriers to fulfilling your full potential." And there you go. That's me getting my PhD from Glyndwr University. So, you know, ugly duckling and swan. Maybe I'm being a little bit over optimistic there, but nevertheless. So, you know, looking at this old photograph of myself 10, 12 years ago now probably, getting my PhD, really makes me think about my position in Glyndwr and what actually Glyndwr and then Newey has done for me. Because I came here and it was here that I first realised that I actually could have an academic career, that there was that opportunity for me. I started here and did my diploma in nursing in the early 1990s, and I'm not the only one here tonight who was also on that same cohort of students, who is now also a member of staff. So there's something that keeps us coming back, which is really nice. So I got my diploma in nursing here. I was a practising nurse at that point. And then after that, I returned again. In 1995, I worked as a senior lecturer here for 7 years, running the then specialist practice community programme, and I taught district nursing at that time. I also studied for my PhD during that time, and I was awarded that in 2003 from this university. And now I'm back for a third time, so hey guys, you just can't keep me away. But what I have to say is I'm very grateful to Glyndwr for kicking off my career and for supporting it since. I'm also grateful to my mother for this. I think she's going to be watching this broadcast tonight, so I believe I'm being filmed. For, you know, keeping me in line, for ensuring that I have dodgy haircuts, strange dresses, and absolutely to this day still keeping me grounded, and I think my family can probably agree with me there. If I feel a bit out of line, she certainly puts me in my place. So. Okay, so a little bit of more self-indulgence. As well as a researcher and an academic, I'm also a proud mother of my 2 daughters who are here tonight in the audience, Primrose and Amber. And as Mike said, Primrose is a student here at Glyndwr as well. I'm also a daughter to my long-suffering mum, and that's us at Christmas of this year. And to my long-suffering husband, Stuart, I'm his wife. And although, if you've known me for a long time, you'll know that I'm a bit of a couch potato, or have been in my life, since meeting Stuart and marrying him, I now have learned to ski, to sail, to hike, to climb, and even been known to do a bit of running, which is really not on my agenda normally as well. So I think it's fair to say now that I'm actually quite an active person. So some of the self-indulgence over there now. So let's get on to the subject of specialist nurses. And there's a lot of you in the audience tonight, and I hope you know that I'm not going to offend you or hurt your feelings about this. I don't think I will be. So let me start by saying what specialist nurses are, for those of you who may not know. So according to the Royal College of Nursing, they're advanced practising nurses with expert knowledge and skills in a particular area of nursing. And they provide direct patient care and play a vital role in educating patients on how best to manage their symptoms. Okay, normally are educated to master's level and caring for patients with a particular range of conditions, such as epilepsy. We have epilepsy specialist nurses, and I'll talk a bit more about those later. Diabetes, cancer, dementia, and so the list goes on now. It's a huge area of niche specialism, if you like. And specialist nurses also work with particular problems, such as incontinence, for example, tissue viability, lymphedema, and again, you know, the list extends. They take on a variety of duties, including specialist psychological, social and physical assessment and intervention, specialist education, and care management. And I'm sure you can tell me about a whole pile more areas that you're working in as well. And according to the RCN survey, not done that long ago, 2010, they're most valued for understanding patient needs, for designing and implementing care pathways, for obtaining patient feedback, and importantly, for being transparent and honest. I think that's a testimony to their work. So I'm sure there's a bit of a consistent theme coming here in the illustrations, because as you can see, it's all about me. Me, 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 me. So here I am, I'll just tell you about these. Here I am taking a special interest in the personal care of my cat, Tommy Spot, who was a Tom and had a spot. So it was quite an inventive name, and a little spot on the top of his head. And in my clinical role here as a specialist community in the home, a district nurse in Mid Wales, probably in the early 90s, I would say. And here, gaining my master's degree, and that's while I was working as a Macmillan clinical nurse specialist. I think one of the difficulties with specialist nursing that's been identified by, for example, the Nursing and Midwifery Council, is that there doesn't seem to be a shared understanding of what the role entails. The problem is also acknowledged by others, and for example, NHS Scotland say a lack of understanding of specialist nursing among the public, service leads and practitioners may reduce the impact and effectiveness of such roles. And the NHS Scotland very helpfully, I think, produced this grid that we have here on the screen. and it talks about explaining the difference between generalist practice and specialist practice, and expert practice and novice practice. And I think it's fair to say that you would expect to see most specialist nurses working in this top left-hand quadrant here. So they're expert nurses and they work in a specialist area with a little bit of leeway, I guess. But in general, I think it's fair to say that. And one thing that is clear, though, that since the 80s, there's been a huge increase in the number of specialist nurses that exist in the UK and the variation in the roles that also exists. And as you can see here, that's meant a huge increase in the number of patients that see specialist nurses in the home and in outpatients. And you'll see from this survey done by Fletcher in 2001, a massive 465% increase since the early 80s when they first really came into force in the UK. But that said, and I think this is due to the current financial climate, more and more specialist nurses are reporting that their role is under threat, and that the health service, as it tries to make financial cuts, is looking at those roles to see whether they're absolutely necessary. And so we have a situation where the Royal College of Nursing point out that more than a third of specialist nurses report that their organisations are freezing vacancies, that they're at risk of having their work, their role downgraded, and they're reporting to have to see more patients. So that's a worrying trend, really. And in some respects, this lack of financial footing makes the post vulnerable. One of the issues with specialist nurses, and I don't know if that's the case for you in the audience, is very often the funding comes, or at least initially comes, from external sources. So that there's been some pump priming from charities, for example, where they pay the first 3 years of the post and then expect the employing authority to take that over, or that they continue to support the role. So we have, for example, Epilepsy Action supporting Sapphire nurses, which are epilepsy specialist nurses. And that means that, again, the financial footing is a little uncertain sometimes. So having set the context a little bit about specialist nursing in the UK, let me tell you about my relationship a little bit more with specialist nursing. Okay, so I was appointed as a Macmillan clinical nurse specialist in palliative care in what was then Powys Healthcare NHS Trust. So Powys, you see on the Welsh map there, is the largest county in Wales, but probably with the smallest population. It's a huge geographical area, but not many people live there, more sheep than people. And there are no district general hospitals. So the post that I took on was a community Macmillan nurse. There are many community hospitals, but no DGHs. So at the time, I was the youngest Macmillan nurse in the UK. I completed my master's degree when I was there, and also a post-registration palliative care module and my postgraduate certificate in education. And that's relevant because it was recognised that all of those skills you really do need. You do need to have a good ability to critique current research, to undertake research, to teach your colleagues and your patients. And so in the specialist area that you're working in. And so all of those skills really are needed. It was a very challenging and I would say rewarding role. Challenging in that we were the very first specialist nurses working in that health trust at the time. And that meant, you know, a little bit of resistance from some people, some challenging from, for example, our medical colleagues asking why nurses now had this area of expertise that had traditionally been theirs. And the other thing that was very evident to me was that in respect of my role, it didn't entirely fill the void that was there. There were patients who really required support and care and hadn't been getting any, and now we came into post, but still we were encountering difficulties. And for example, funded by Cancer Relief Macmillan Fund at the time, which obviously meant we were working with patients who were terminally ill from cancer. There were also a number of other patients there, terminally ill, but whose condition was not cancer. And so they didn't receive any specialist nursing care at the time. And so we were required to take on that role as well. There were no breast care nurses either, and so we were also trying to do that. So it was a difficult time. So there were some political challenges and some clinical challenges, but it was extremely rewarding as well, and I'm sure that's why many of you stay in that specialist role now. I'm pleased to say that that's not the situation now, that there's been a huge increase, as I said earlier, in the number of specialist nurses, and in that county, of that now local health board, there are many more specialist nurses. Okay. So I'll take you now to some of the studies that I've worked on. So having worked as a Macmillan nurse, I then came here to working what was at the time Newey as a senior lecturer, and of course that means that we're undertaking research as well. And so whilst I was here, I undertook a number of research studies that were commissioned by external bodies, and one of these related to breast care nurses, and I think I actually interviewed one of you at that time, so in the late 90s. So we undertook a series of studies looking at the role of the clinical nurse specialist in North Wales and the role of breast care nurses in North Wales. And even at that early time, it was very evident was that the specialist nurse absolutely improved the quality of care of patients. And if anything, people wanted to see more of that role in North Wales at the time. So I'll take a bit of a leap now until I'm working in John Moores University, which was in the early when did I go there? 2005, actually, mid-2000s. And there we were, my team and I, commissioned to undertake a study by Breakthrough Breast Cancer. And that was to look at the role of the breast care nursing service in England. And the reasons, I think, the backdrop to that, if you like, was looking at things like patients identified as being particularly supportive of the role of breast care nurses, wanting their support from breast care nurses rather than other professionals. Breast care nurses also being valued by their colleagues for handling things like bereavement, actually, in the literature, and symptom management, greatly valued, and also identified in the literature that breast care nurses, and I'm sure you can say this as well, take on a range of professional roles. So in some respects, that was some of the backdrop. But also there was evidence of the challenges associated with the role. And one of those is about challenges of adequately defining the role, what that means. It's open to quite a lot of interpretation. But what's clear is that there are some key elements of the role. Communication, rapport and awareness of women's needs, and men's in some cases. The availability of the nurse is highly valued. The reassurance that patients receive from having their input, and the practical information that they give. And again, what was very evident in the literature was that the financial challenges are meaning that that role is being challenged as well. And that was the backdrop to why we were commissioned to undertake this work. So in some respects, Breakthrough Breast Cancer were wanting some evidence of the value of the role. So we were commissioned to undertake this national study, and what it involved essentially was 3 elements of a study. So we undertook questionnaires with breast care nurses working throughout England, and there were a range of questions there looking at what roles they undertook, what aspects of the role they thought would not be undertaken should they not be in post, how much of their time they were spending with patients and in direct patient care, the types of things that they were doing in that role. It was quite comprehensive. We also sent out a questionnaire survey to patients, and we recruited patients both through breast care nurses and separately through charity websites, so that we had patients who were receiving breast care services and had either directly been recruited from their nurses or had been recruited elsewhere, so that we could show that there wasn't a bias to their opinions. And finally, we also undertook some case study work. We worked in 2 case study hospitals and 1 control site, and what we did there was undertake work with the nurses, asking them to complete, for example, diaries. We also shadowed them and followed them and did some sort of observation work with them, and we managed unusually to find 1 control site, and that was a hospital where there were no breast care nurses in post, and I think in this day that's quite unusual. So I'll just share some of the findings with you from that study. Okay. Interestingly, core activities of breast care nurse are clinical, education, support and counselling. I think no surprises there really. What is comforting to hear, and I'm sure from a patient's perspective comforting to hear, is approximately 75% of their time is taken up working directly with patients or on patient-related activities. So those sort of thoughts of grandiose nurses not ever having any contact with the patients is completely unfounded, actually. Most of their work is patient-related. And the remaining part of the time, that 25%, is dedicated to teaching professionals and patients and carers, and also to undertake research to move the practice forward and to audit their activities. So in effect, they're basically working appropriately in their role and undertaking work that you would expect them to be doing. Most breast care nurses hold a caseload, and most of them said that their mean sort of caseload size was about 140. There were some huge variations, but evident from the literature and from talking to people, about 100 is a manageable load. So you can see that their workloads are high. And as you might expect, we analysed diaries. We asked them to complete diaries every day of their activity over a month's period, so we had an idea of what they were undertaking. And as you might anticipate, they're working to full capacity, and that means doing things like taking home admin work in the evenings, etc. So working outside of their hours. Okay. 88% of patients who receive a diagnosis of breast cancer had a breast care nurse present when that diagnosis was given to them. And I think that's quite a comforting statistic. Breast care nurses were most frequently chosen as the person they'd prefer to receive all listed types of advice, from coping with diagnosis, symptom management, body image, patient support groups, family support. So there's a huge support role there that's highly valued by patients. It's evident that nurses engage in many subspecialties, and so they may be involved with things like lymphedema care, reconstruction care, counselling, and other areas, diagnostics in some cases as well. What was difficult for us as researchers was we were trying to make the case, or to look at the case, I should say, not coming with a bias, of the economic value of the nurses, and that's where we really struggled, actually, because there is just not the evidence out there. What tends to happen is that different healthcare trusts or nurses are collecting their own data to demonstrate the value of their role, so they're undertaking audits, but when you try to compare that across different organisations, that data isn't available or not comparable. And so we really struggled with the economic. We had a health economist on board, and she really struggled with this part of the work. What we could say was the cost per patient of a consultant-led outpatient appointment was reduced if there was a breast care nurse working alongside the consultant, because there was evidence of their input there, and therefore reduction in the time that the consultants were spending with the patient. And what's evident from the support of colleagues was that adequate resourcing of the breast care nursing service is crucial to the delivery of high quality care, and that limited resources leads to compromised care. And I think what was very important from this research, and shouldn't be overlooked or dismissed in any way, was the support that the breast care nurses were getting from their other colleagues. And so you can see from these quotes here from mainly consultants, managers, we also spoke to a number of other different colleagues as well, that their role is indispensable. And without that role, and that was a clear message, some of the care that patients receive, the high quality, highly valued care, just wouldn't be given. Okay. So at a pretty similar time, I was also with a team of researchers commissioned by Epilepsy Action to look at the role of the epilepsy specialist nurse and establish the costs and benefits of the epilepsy nursing service. And for this, we undertook 4 different parts of the study. We sent a questionnaire to epilepsy specialist nurses, again in England. We interviewed epilepsy specialist nurses in focus groups. We sent a questionnaire survey to neurologists, and we undertook again the case study approach. So we were using a very similar approach, learning from our other experiences really. So it looked like this. The focus groups took place in the East Midlands, in London, and one in the North West. Our case studies, we had 4, a district general hospital, a teaching hospital, a primary care trust, and one control site where there were no epilepsy specialist nurses. They were easier to find, actually, those case sites, than were breast care nurses. I think most places have a breast care nurse. It's a bit hit and miss whether people have an epilepsy specialist nurse. Okay. So just to give you a flavour of this, the questionnaire went out to all epilepsy specialist nurses who care for adults in the UK. And there are about 137 as far as, this is Epilepsy Actions database, but we also went to ESNA, which is the Epilepsy Specialist Nurse Association, so we're pretty sure we captured most. And 87 of those completed the questionnaire for us. That gives us a response rate of 64%, which actually is pretty good. We were pretty pleased with that. We also then interviewed specialist nurses themselves. So we held these focus groups. We had 19 participants in total. And we really asked people to engage in a dialogue with each other and discuss their professional experiences. And those were audio recorded and transcribed. We sent out questionnaires to neurologists, 174 of them, and we, knowing how hard they are to reach, we tried to get to them with an electronic form of the questionnaire, hard copies and online versions. And similarly, we asked about their experiences of working with epilepsy specialist nurses, got 59 returned questionnaires with a response rate of 34%. Now, I guess people would think that's pretty poor, but actually if you know the literature or you've worked with doctors in other research studies, that's about what you can expect. Actually, they're not so good. And I think part of that is because actually they're bombarded with research. Nurses are as well, but I think sometimes doctors are more. So we put it down to that, and maybe a bit of reluctance on their part. We tried very hard. We also did the case studies, and really that's where it's really illuminative, where you get a lot of your information, the qualitative. You can see I'm a qualitative researcher. It's getting to the crux of what people have to say. So we asked people to complete a diary, again, epilepsy specialist nurses. That was a diary that's been validated in literature previously. We also observed them in their practice. We sat in on patient consultations. Obviously, we had the ethical approval to do that. And on their other activities, such as multidisciplinary team meetings, for example. And we undertook interviews with some of the stakeholders who work with epilepsy specialist nurses, both in the case sites where there were nurses and in the control site, to have a feeling of what they thought about not having a nurse and why that might have happened. We also then went and collected secondary data, and I mean the data that's already collected in hospitals and primary care trusts, to look at what epilepsy-related activity there is available. Okay, so some of the results. It's very evident that epilepsy nurses are quite confident in their practice, and they were confident in taking on their autonomous role. And that was very evident. So they had quite a high clinical element of their role, taking on responsibility for decisions, making diagnoses, asking for tests, etc., changing medication. So quite high-level clinical activity they were involved in. 20% had a master's degree, 43% a bachelor's degree, and 80% had a qualification which was specifically related to epilepsy. So highly qualified. 41% of the nurses were also prescribers, so they were prescribing for their patients. Again, a high level of their time is spent directly in patient care, and an awful lot of their work is related to drug reviews, drug change, managing medication. Got ahead of myself now. One of the things that was interesting was looking at their rationale and their position related to prescribing, not just the nurses themselves, but also their colleagues. And it was quite equivocal in that some people felt that epilepsy specialist nurses didn't need to prescribe, and didn't need to because they were working closely with consultants who were able to do that. There was also quite an interesting undercurrent, which was nurses saying, well, actually, we're nurses, we're not doctors, we're here as nurses, and if we take our eye off the nursing ball and the important aspects of that, which is caring for people, being available, being supportive, and we take more of a sort of a role in the clinical elements, we might actually lose the very essence of what we're supposed to be doing, which is being nurses. And that comes out in the literature quite a bit. So that was interesting. 67, beg your pardon, held a caseload. Massive caseloads. 570 was the mean. Some were holding caseloads of thousands of patients, shockingly. And most agreed that this absolutely wasn't ideal. And one of the issues, the underlying issues, was because people with epilepsy don't get cured, they've always got epilepsy, and therefore they always need input at some time from an epilepsy specialist nurse. So what they were seeing was these burgeoning caseloads that just were getting bigger and bigger and bigger, and somehow having to prioritise those. Again, very evident that there was a lot of support from colleagues, so consultants talking about them being the saving grace. That very clearly it comes out that they're not the icing on the cake. They're not some special thing that happens when times are good and that you can take it away when times are not so good. Specialist nurses are indispensable, and they're an absolute, hugely important part of the team. And again, the message coming out that should they not be imposed, then some of the really important elements of care that patients are receiving would be lost. They would not receive that care any longer. And a real strong element of support from the consultants, including, interestingly, the case study where they were in a situation, and I don't think I've shared the quote here, but the consultant saying, when I started out in this role, I truly believed that I didn't need a specialist nurse, that I actually could get along quite nicely without them, thank you very much. And now I'm actually trying to make the case and fight for my corner to be able to find the funding to support that role, because I've been convinced by my colleagues that this is absolutely necessary. So even in those areas where there wasn't that support initially, the times have changed. Okay. Here's my lovely husband. He's here in the audience. He, a couple of years ago, did the round the world clipper sailing race, yacht race. And he did the leg that went from, where did you go from? Tell me, shout. China, across the Pacific to San Francisco. So really, really demanding and actually quite treacherous. And this is me on San Francisco, just under the Golden Gate Bridge, welcoming him home, and really feeling glad that he was back and that he'd used his specialist skills to get across this really treacherous water. But he's a wily guy, you know, because what he does know is in those situations, when you're going across treacherous waters, you do need an absolute specialist. But hey, when you're crossing the Ionian, you can use one of your galley slaves, and that's me at the helm. So the same principle really applies in the health service. And what was quite disappointing, I suppose, but it's becoming more prominent that in the health service is that that specialist role is being eroded. And that's because we had quite a lot of reports of nurses saying that in times of trouble, they were being pulled from their clinical area, their specialist area, and asked to go and help on the wards, for example. And being asked to help on the wards meant that they were coming away from their specialist area. And in some respects, that's quite not very judicious. And I say that for two reasons. One, it means that the patients that they should be caring for suddenly lose their specialist nurse. And they're also then in a situation on a ward where they're, you know, it's unfamiliar territory again. It's been a while since you've worked in that area. And so they're operating at the novice generalist area. And so therefore their salaries, you know, are being paid at a higher rate, and they're fulfilling a role at a lower rate. So it doesn't seem very well conceived, that strategy, but you can see that it's starting to happen. So it's quite imprudent. And it's worrying to hear that that's happening more and more. And I can see a few heads nodding there, actually, as well. We also, as I said, set out to take, again, another economic evaluation to gather all sorts of data that we thought we'd be able to access. Things like inpatient admissions, A&E attendances, outpatient attendances, and to compare these across sites. But we couldn't get the data. Again, it was a real problem. And so we could only look at particular data, but found some. Essentially, some trusts were collecting data related specifically to epilepsy. Some were just collecting it in relation to neurology in general, and so we couldn't drill down and get that information. So that's a bit disappointing, and that work needs to be done in a way. What that meant was that there wasn't a real clear message that there is economic value to the role of the specialist nurse. That's not to say it isn't there, but we weren't able to demonstrate it. Okay, just to tell you a few of the publications that have come from this work, and it's been widely published. And actually, when I was doing this preparation for this lecture, I find that it's being quite widely quoted now as well, which is quite pleasing to see. So from the Epilepsy Professional, where Epilepsy Action have published something that we wrote, and also in the Journal of Advanced Nursing. Okay, I move on to another study that I undertook whilst I was in Liverpool again, and it was looking at the role of the community matron. Community matrons in England these were domiciliary community matrons, okay, so they're working in patients' homes. They're not, you also have matrons who work in residential care or in nursing homes as well. And they work in England with patients who have chronic conditions, and who are in a situation, the nurses are in a situation where they're managing symptoms and trying to prevent admissions to hospital that are unnecessary. And so they're working, for example, with people with chronic obstructive pulmonary disease, but many other conditions as well. And at the time, Liverpool Primary Care Trust had just employed 54 community matrons, and they were very keen to see how they were working in practice and how effective they were. And so they asked us to undertake this role. And so what we did was we actually observed the domiciliary community matrons whilst they were in practice and engaged in patient-related activities. And we developed a competency framework based on, for nurses who know, on the work of Benner. So we looked at the work from novice through to expert and graded them in a number of different care situations. We also interviewed them after that intervention to hear about the decisions that they've made and what evidence they were using to base those decisions on. And we got ethics approval for that work. Okay, we actually observed 18 episodes of care, and some of the interesting things were that the nurses had been qualified from between 13 years and 42 years. So they were very, very experienced nurses. Many of them had been experienced district nurses or community nurses or specialist nurses prior to this role, and a number had worked in hospitals in specialist areas as well. All, I don't know if I said all three, but all had completed some sort of postgraduate programme relevant to their study, relevant to their role, and all but one held a prescribing qualification, and that one was currently studying for that. So they were doing an awful lot of prescribing as well, and that seemed to be key. And of those 18 episodes of care that we looked at, in 12 situations it was very evident that they were experts, and 6 that they were proficient, so at the higher end of the scale also. It's not by any chance that I put a picture of my mother there again, because if you look at some of the things here, it says that expert or proficient practitioners very much had a patient-centred approach to care, that their practice was absolutely evidence-based, because that was one of the things we were asking them. Why did you make that decision? And they were talking about some of the literature that they'd read, or some of the pathways which had been developed on the basis of evidence that they were working to. They were clearly working in a multidisciplinary situation, and they were providing a range of services that meet what the Department of Health say that community matrons should be doing, and that's essentially keeping patients out of hospital and keeping them well managed within the confines of their condition. So my picture of my mum is there because I honestly, hand on heart, come away saying that my 87-year-old mother, who's fit and well and lives alone and independently, should she require the care of a community matron, I would honestly feel very, very happy that she was receiving excellent care. And I think that is a really important benchmark to think about when you're judging the care of patients. So in that situation, I really, truly believe that that's the case. So then, what's so special about specialist nurses? Okay. Let me tell you about these pictures first. So these are more pictures of my family. Top picture, my daughter's husband, one of my stepsons, I have 3 stepsons, and his wife and daughter. And here, my granddaughter, step-granddaughter if you like, Daisy, who's very, very special to me, and you can see that sometimes I'm quite special to her as well, which is very nice. But what's so special about nurses is really what we're asking. Well, they're highly qualified. they're experts in their field, and I think that's really important to take away. Most of the specialist nurses have high-level qualifications. Their focus is on patient care, and it is very much on the clinical care, but also the emotional, psychological, social elements of the care, so the whole holistic approach. It's clear that as a result of specialist nurses being in post, that absolutely they contribute to service improvement and improved quality of care. And unfortunately at this point, the economic value of their role, we have limited evidence of that. And that's in general in the literature as well. Okay, so where do we go next? Well, at this point in time, I'm just embarking on 2 newly commissioned studies. The first, now again related to epilepsy care, funded by the Health Technology Assessment National Institute for Health Research, is going to be looking at epilepsy specialist nurses for learning disabilities, and the other related to tissue viability nursing. So I'll tell you a little bit about them before I finish up. So the first then, I'm quite proud of this. Some of you will have heard me talking about it before. I was approached by the University of Cambridge to work with them to develop a research proposal based on my epilepsy nursing work to look specifically at the role of nurses who are working with people with intellectual or learning disabilities. And it's particularly to look at nurse-led epilepsy management, and that's why I was asked to join them. So that my colleague is a consultant psychiatrist with a specialist area in learning disability. And essentially we're setting out to look at whether nurses with an expertise in epilepsy and intellectual disability can improve clinical care, and whether there are any value for money benefits associated with that. Okay, so what we're going to be doing, complicated blind cluster randomized trial with 2 arms of treatment as usual arms, so patients will receive just the care that they've always received, and then another defined epilepsy nurse role. So I've been working with a group of community learning disability epilepsy specialist nurses to write competencies, which are just, I think have now been published by the Royal College of Nursing, and so they're going to be the baseline for the intervention. And we're going to be asking nurses to work within those competencies to this defined role. And we're going to be following the care of the patients who receive their care and undertaking some baseline measures and then measures at 6 months and 12 months. Okay, I'll take you back there for a minute. We're going to be looking at things like quality of life, economic outcomes, quality of carers' lives as well, and the impact that nurses have on their care too, and their relationship also with other clinicians and how they work as part of a team. So that's going to be really interesting. It's very well funded. It's from the National Institute for Health Research, £850,000 worth of research money, and we have to undertake that over about 18 months. So it's going to be an awful lot of hard work. And the other study that I'm also just started to be involved in is the Pressure Ulcer Prevention and Intervention Service within Betsy Cadwallader NHS Trust. And that's a team that I've been invited to join, and that's Nigel Shapcott, Nesta McCluskey, Julie MacDonald and Fran Whitehurst, the tissue viability nurse who's sitting in the audience, which is very nice to see you here, Fran. So we've just received some money, and we're going to, over a year, look at tissue viability nursing and other interventions to see whether a difference can be made to long-standing pressure ulcers, if you like. So some of the things that we're going to do here, again, it's about collecting data early on and then over a period of time. And in both of these studies, the important thing, I think, is that they're exciting and challenging because they're going to lead to, amongst other things, some sort of basis to demonstrate the economic value of nurses, specialist nurses, and I think that's the little area that's been missing. So I'm feeling very excited about them both. Okay, really that's bringing me kind of to the end of the presentation now, so where do we go from here? Well, save our specialists would be my first message in a way. And if you look at some of the charity work that's happening, for example, Epilepsy Action have a Save Our Sapphires campaign at the moment. Sapphire nurses are their epilepsy specialist nurses. So I think we really should be really shouting that message out, that nurses have a huge value for patient care, and patients will be disadvantaged if they no longer receive that specialist care. Okay, diolch yn fawr I chi am wrando. Gobeithio'r digwyddiad fod o defnydd I chi, a bod chi'n gadael yma heno gyda gwell gwerthfawrogiad o cyfraniad ap hebgor y mae nyrsys arbenigol yn ei wneud I ofal cleifion mewn ystod eang o leoliadau gwahanol. What I've tried to do tonight is demonstrate that objective research provides a convincing argument that specialist nurses are invaluable. And I think when healthcare providers are trying to balance the books, one of the things that they should consider is closing down specialist nursing services is ill-conceived, and it will lead to compromised patient care. And I hope that for nurses here, you can go away with that message. But an important message to you is that you are able to demonstrate that yourselves, and that means you being more business astute and collecting your data to demonstrate and justify your roles, because unfortunately sometimes that's the position that you find yourselves in now. So that research work, that audit work, and also working with your partners in other NHS organisations is going to be your strength and your future in a way. So, what I'm going to do now, I'm going to go and have a drink. It would be lovely if you joined me. I think there's going to be some refreshments out there. Then I'm going to go and put my feet up because I think I deserve it now. And finally, this is, you know, what I do at the end of all these horrible hiking holidays that Stuart takes me on. I'm seriously going to have a lie down. And so please, if you have any questions, ask me now and then join me afterwards for a drink. Thank you very much.
Thank you very much indeed. Questions, please.
Thank you very much, Fiona. That was a really excellent presentation, and as a specialist nurse, it's really nice to hear all that. I'm just kind of interested, because I know I've got a lot of colleagues in the audience here. I'm already got a research agenda, and they're going to be meeting you.
Yes, very soon, yes.
I'm kind of a research interest, but has the title University, and at the moment what I see with my colleagues trying to gather data and do things, are perhaps not doing that with a very academic hat on.
Okay.
I'm just wondering what your suggestions to them in the audience as to how we might better engage with our local university, because at the moment it's quite difficult to know, perhaps on the shop floor, how to forge those sort of relationships.
That's an excellent and very timely question, actually, because we are just starting to do some work, and Debbie Roberts, the reader in nursing here, is going to be leading that. So we've already started working with Powys, and Debbie's going to be doing some work specifically with the specialist nurses in Powys, developing things like their leadership skills, their research skills, and working with them to identify areas that they particularly need to concentrate on, and developing those, you know, quite specific research skills. They're very clearly very expert nurses, but it's a particular niche area that they need to work in with us as researchers. And we've also been talking to one of the managers in, I won't name her because it's not fair in this audience, but in Betsy Cadwallader Trust, to look at how we can do a similar piece of work with the nurses in Betsy Cadwallader. The difference is that there are a large number of specialist nurses in Betsy Cadwallader, and because of the nature of Powys being not having a district general hospital, quite a smaller number there. And so in some respects the needs might be different, the skill mix is different, I think, in the two areas. But I would say, you know, I'll happily give you my card, and Debbie's here in the audience, and we'd be absolutely delighted to work with you to help support you to demonstrate how your role is valued. Hello.
We come up here, that's the great thing we need to tell people. We need more specialist nurses. I say that because I've got Parkinson's. It took me 16 years to get a specialist nurse to come here. And which, the way you put it across, it seems so easy to get a specialist nurse. It's not.
No.
It's a long battle. Thank you very much for helping us push it out.
I appreciate that. It is absolutely a long battle. And you know, my experience in the 90s with cancer patients was that I was shocked at some of the patients that I saw. and the fact that they had never received any specialist input was quite shocking. And I think what's disappointing in some respects is that it's so different across the country. That's my experience with the research in England, so that in some areas their patients are very well served, and in others they're just not. And in some respect, in relation to things like Parkinson's disease and many other particular conditions, it's often the charities that are doing the work to engage those nurses in the first place, and then trying to have a dialogue with the National Health Service to encourage them to take on the salary role, if you like, and continue to support that once they've been in place for a time. And so they're relying on the donations of family and friends and people who have a particular interest in that area. So I don't underestimate how difficult it is. And hopefully, you know, this work and the published work in some respects will make a little bit of difference at least.
We actually got to sit in on some of the panels when they were discussing the proposed neurological services for whole of North Wales now that they were changing. And what concerned us was that Liverpool were veering more towards generic nurses rather than condition specific.
Yes.
I mean, our nurse has been Wrexham's been in post for 2 years and she's virtually at full workload now. Well, she's got to take on another condition as well. She's not going to have the time, she's not going to have the expertise. So we're a bit concerned that Liverpool is veering towards generic nurses rather than condition specific.
I think that is a concern, because I think if you remember that first diagram that I showed, what you really want from your nurse is, at least, you know, the leaders in that area, is that they are at that expert area and they are specialists. So if they're taking on more than one specialism, then of course, you know, that's diluted in some way. And so then they become less expert.
But when we had the first nurse in North Wales, she was Sally, based at Glyndwr Hospital, Glyndwr, and she actually did a business case to see how much money she'd actually saved over the first 12 months she was in post. And it was absolutely amazing how much she actually saved. So that was used as an example to go around all the other health boards and to push for more specialist nurses because of the amount of money she had.
And that's the key in a way, and that's some of the work that Debbie will be doing with staff, is to be able to support them to develop those business cases, to make the case, if you like. Any other questions? One right at the back.
I was thinking about my dissertation to do it on the cost and benefit of having an specialist practice nurse. If I was to then undertake that when I graduate and went into management and management, I think that would then be in my favour, so that I've got a justification for my own research. But then I do want to become a specialist practitioner, and I've got that evidence to support why I think wanting to be a management nurse and not that management.
It's lovely to hear that you're already thinking of your career pathway like that, and I think it's really important, because actually the decisions you make at this early stage can well direct you in the future. So wholeheartedly I would say, if that's what you have in mind, then starting out at this point and producing a dissertation based on evidence is only going to set you in good stead for that future role. So well done you for thinking about it right now, and absolutely right. Okay.
Well, can I take the opportunity to thank Fiona? It's been a really interesting lecture. I think brought to our attention not just the quality of the specialist nurse, but the problem that we're facing in society, in the sense that our society somehow isn't getting its finances right in a lot of very fundamental areas. And that can't go on, really. And in a sense, it's in our hands that we have to come to events like tonight. We have to pressure, talk about things that really matter. And one of the things that really matters is that we look after people in our community, and we look after them in a proper way. And that's what you've shown us today. That's what it's about. We have a new Minister of Health today, appointed today, Mark Drayford. There you are. Why not write to him, welcome him, and just remind him of the role of the specialist nurse and how important it is within our society. Fiona, thanks very much.
Thank
Thanks
you.
for being here.
Thank you. Thank you.